So tonight he'll be sharing an updated and practical approach to one of the most common and often misunderstood cause of vertigo in our clinics, BPPV. With that, I would like to welcome Dr. Puravi for his talk, When the World Spins, an updated approach to BPPV.
First of all, I would like to thank MMA Sabah and Dr. Dinesh to give me an opportunity to talk on this Zoom meeting. Good evening to everyone. Today, we are diving into an update approach of benign paroxysmal positional vertigo, or BPPV. As clinicians know, um, that BPPV has got a lot of impact on patients' life. And recent advancements have brought new insights into the diagnosis of and the management of BPPV. Before we dwell deeper, let's revisit the fundamentals of balance, exploring our visual, vestibular, and proprioception system work in harmony. Now, the physiology of balance, which is complex and multifactorial. All the information from the sensory input, which is the visual input, vestibular input, proprioceptive input, is sent to the central processing system, which is the brainstem, cerebellum, and the cerebrum. And the final motor output information from the motor cortex is sent down to the muscle through the corticospinal tract and fine-tuned by the cerebellum to maintain good balance. Now, as you know, visual input is very important for balance. So balance depends not only on visual acuity, but also on proper control of eye movement. There are 6 eye movement system, which is the saccadic system, smooth pursuit, vergence, fixation system, vestibular ocular reflex system, and optokinetic. All of these are coordinated by the cerebellum. The eye movement ensures the vision remains clear and stable during head and body motion, allowing the brain accurately perceive spatial orientation. We will look at the saccadic eye movement. Saccadic eye movement is used for gazing around or quick reading, and it is rapid ballistic eye movement at 700 degrees per second, can go up to 700 degrees per second. You can see this is the VNG graph accurately. The saccades are quite accurate. The red shows the right eye, the blue shows the left eye. Now, what happens if your saccade is not working well? So, if the saccade is not working well, what happens is you will have saccadic inaccuracy. So you can see on the graph here, let me, 1 minute. So you can see this is the multi-step saccade, like dysmetria, like you do finger to nose test where the hand, the finger does not touch the nose and the finger test, it's not accurate. So there's a dysmetria. So these kind of patterns are seen in Parkinson's or multiple sclerosis and cerebellar disorder. So the basically the um, the animation, sorry, the eye movement. This is the saccadic inaccuracy. So you can see this is the stimulation of eye movement. The patient actually sees blurring of vision. This is what you see in patients with hypometric saccade or saccadic inaccuracy. Next is the smooth pursuit. Smooth pursuit is to track moving objects when the subject is stationary, like tracking a bird flying. So the smooth pursuit is to keep the image is always on the fovea to get a clear vision. So you can see the graph here. The red color is the right eye, the blue color is the left eye. It's quite smooth. Now, if a patient has got saccadic smooth pursuit, you can see on the VNG graph, the smooth pursuit is not smooth anymore, it's very saccadic. So this is the eye movement. And the stimulation, you will see patient actually when they have saccadic smooth pursuit, when they read, this is the words jumps here and there. So this kind of pattern is seen in brainstem or cerebellar stroke, or even in migraine. Some of the patients can have this, especially vestibular migraine. Patient will come and complain, doctor, I feel dizzy, imbalance, I'm not myself anymore. But we translate it into vertigo and give them anti-vertigo medication. Next is visual fixation. So, visual fixation to help maintain steady gaze on stationary object and prevent eyes from drifting. So, you can see the image here, the video here. So, you can see there is a gaze evoked nystagmus on the right side. The patient look at the right side, you can have a small right beating nystagmus, and the video below, you can see on the primary gaze itself, you can see a left beating nystagmus. So you can see the left beating, and on the left gaze is more obvious. This follows the Alexander's law. So basically, this is what the stimulation they see. The vision becomes blurred, especially when they see the extreme side. So this kind of lesions, this kind of pattern can be seen in the cerebellum, midbrain, or pons lesions, and patient can where they can develop gaze evoked nystagmus. This is more of a central pathology. Next is optokinetic nystagmus, which occurs when viewing a continuously moving visual scene, such as looking out of the car or train window at evenly spaced light bars, okay, or light poles. So the eye smoothly follows. First, you have a smooth pursuit. It follows the object, and that's a slow phase until it leaves the visual field. The light pole leaves the visual field. Then you have a fast saccadic eye movement to the new pole. So the importance of this optokinetic nystagmus is it maintains visual stability during sustained motion. So if you are in motion, you need the optokinetic work. If your optokinetic system does not work, then the patient will experience blurred or unstable vision. Sometimes they can have motion sickness. OKN is usually preserved in peripheral vestibular disorders, but it is in central pathology, it will be absent or asymmetry. Next is vergence. It's a type of eye movement where both eye moves in opposite direction. Almost all the eye movement just now I mentioned is a conjugate eye movement, whereas vergent is a disconjugate eye movement, basically to maintain binocular vision. So there are two types of vergent. One is convergent when you're seeing near, or divergent when you're seeing far. So with all this eye movement, so like when a tiger hunts, it first uses its saccadic system, rapidly scans around it. So it's using its rapid saccade system, and then it tracks the deer with a smooth pursuit. During the chase, when it starts chasing, it will use the optokinetic and the vestibular ocular reflex. Optokinetic on the background working so that it doesn't hit the trees. And finally, when he strikes the deer's neck, the tiger uses his visual fixation to lock his gaze precisely on the target. All this eye movement is controlled by the cerebellum to get a clear vision. Now, I've spoken about the eye movement. What I did not talk on was the vestibular ocular reflex. That one I will talk on the vestibular system itself. So, as you know, the inner ear has got 6 end organs, and everyone knows cochlea is for hearing, but actually it's not true. It can also use for spatial localization. So the inner ear consists of the cochlea, 3 semicircular canal, the utricle, and saccule. Now, this is Ben Underwood, where his both eyes were removed at the age of 3 years old because of retinoblastoma. He had a prosthesis eye. So Ben Underwood actually uses his cochlea to do echolocation, to navigate, making clicking sounds with his mouth, so that he makes When he walks around, he makes a clicking sound. So he will listen to the echoes that reflects back from the object, like the bats and dolphin. He can walk, run independently, ride bicycle, play basketball, and actually his brain adapts through the neuroplasticity. So while walking the stairs, he actually makes clicking noise. He knows how far is the distance of the object. So this proves cochlea can do spatial awareness because they arise from the same neuroepithelium. The otic placoid appears at the third week of gestation, differentiate into the membranous labyrinth, forming the cochlear, semicircular canal, and otolith. So its utricle and saccule also can be stimulated by sound. This is the basis of a WAM test. Now, so I spoke about the cochlea. Next is the utricle and saccule. So what is the function of the utricle and saccule? Is to detect linear acceleration. So one linear acceleration always present in Earth is gravity. So a construction worker uses something heavy like an iron. A mason uses an iron to detect the line of gravity when he builds the brick wall. So what biology uses is a stone, which is calcium carbonate. So if a stone in the kidney is called nephrolith, then in the ear it should be called as a otolith. So the utricle, otolith is basically the utricle and the saccule. So even in aquatic animals like fish has got otolith to know what is up and down. So the function of the utricle is to detect forward, backwards, or side to side. Whereas saccule, you can see the otoconia on the utricle on the above diagram, and the below is the otoconia on the saccule. So when you go up and down, it's detected by the saccule. So what is the function of utricle and saccule? End function of the utricle and saccule is for postural control, or also known as through the vestibular spinal reflex or vestibular colic reflex. So otolith, which is utricle and saccule, is a biological accelerometer because it detects linear accelerator. So it's a linear accelerator, detects linear acceleration. So it is an accelerometer. So it detects head tilt relative to gravity and then controls by postural stability. There are two types of reflex. One is called the vestibulo spinal reflex. Another one is called the vestibulo colic reflex. Now, if someone pushes you from the back, the utricle senses it. Then the vestibular spinal reflex activates so that anti-gravity muscles, especially the paraspinal muscles, gluteus, soleus muscle will contract to keep you stable. So when in the car, if you're in the car, when the car brakes, the head moves forward. So your utricle senses this. Then through your vestibular colic reflex, it will activate your neck muscles, your sternocleidomastoid, your splenius, deep neck muscles, extensors will contract to stabilize the head on the trunk. So there are four types of motor strategies for balance control. One is called the ankle, hip, suspension, and stepping. So this is a uh, ankle strategy. When there is a low amplitude perturbation is applied, that means somebody pushes your back with a wide base of support, what happens is your ankle proprioception detects this information and sends to the cerebellum, and then in return through the corticospinal tract, the motor, basically your gastrocnemius and your hamstring muscle contract to maintain stability. This is if you're a narrow base of support and somebody pushes you, what you're using is your utricle senses this, and then through the vestibulospinal reflex, your gluteus muscle and paraspinal muscles contracts to maintain stability. If you're walking in a slippery flaw, then you will use your suspensory strategy to maintain stability. And if the push is too strong, this can cause a stepping strategy. So now we have learned about utricle and sacule. So what happens if you have a weakness in the utricle and sacule? So some of our patients will have utriculopathy or sacculopathy. So how do they present? They present with, they feel like walking on the wool, not very stable. They have excessive dependent because the utricular function is not working. So they become excessively dependent on proprioception and vision. So they will have difficulty walking on grass or uneven surface or walking in dark places because they are totally dependent on the vision. So the vestibular system is not working. So they say they are not sure-footed. Or sometimes when they walk, they veer to one side. Or what happens is in some patients, especially when the utricular function is affected, the patient suddenly have the line of gravity actually shifts like this. Like this patient suddenly have a forceful fall. This is called a Tumakin crisis. Normally occurs in advanced Meniere's disease. So the patient actually, the line of gravity, because the utricular function, this is the line of gravity. Suddenly for the patient, the line of gravity is this way. So what happens is that the patient thinks now the whole world is straight like this. So there's like a sudden force that pushes him down. So these are the problems you patient will face when they have utricle or sacculopathies. Now, next is the most important that we have to know is the three semicircular canals. They are arranged at 90 degrees to each other and they detect angular acceleration. The only angular acceleration is actually rotation. So there are three planes. One is called this is called a yaw plane, this is called a pitch plane, and this is called a roll plane. So these are the functions of the semicircular canal. Now, we have learned that otolith's function is postural stability through vestibular spinal reflex and vestibular colic reflex. So what is the function of the semicircular canal? Actually, semicircular canal is an organ of vision. So basically, the main function of semicircular canal is for gaze stabilization. So I've covered the basics of a saccadic system, including smooth pursuit, vergence, visual fixation, and optokinetic. But VOR is very important for stabilizing the vision. So the VR works by coordinating the semicircular canal with the extraocular muscle, ensuring your vision remains stable even when the head moves. I've also mentioned that vestibular spinal reflex and vestibular colic reflex, which is the sense of otolith. But now we have to focus on the vestibular ocular reflex to help us to maintain a clarity of vision. Let's look at the in detail. We humans are foveated animals. That means through evolution, we are foveated animals, whereas rabbits are not foveated animals. That means the whole retina is like a fovea for them. But for human, all the retina contains the fovea, which is so the retina contains the fovea, which is in the center. And in the periphery, you don't have much cone cells and dense and rod cells. So all for sharp vision, the image should be fall on the fovea, where the cone and rod cells are densely packed. So we will do a simple experiment. I want you to stretch your thumb, both thumbs, and look at your right thumb. So when you're focusing on your right thumb, what is the clarity of the left thumb? Just focus on your right thumb. You will see that the left thumb is not so clear. Basically, the right thumb actually falls here, whereas the left thumb falls here. So you can see both thumbs are closed, but when about 2.5 degrees, you can find there's more than 50% loss of visual acuity. So basically, the fovea is very important because that's where all the information goes in. If our entire retina is like a fovea, then the workload for the brain will be immense. Brain has to process every point. So I think the optic nerve will be this thick if our whole retina is a fovea. So the fovea is only used for fine and sharp work, and we need less than 2 degrees needed to get the clear vision. That is the reason why our eye has to move. So when we track a object, we activate our smooth pursuit. If you scan, then we are using your saccadic eye movement. Now, remember the olden days camera, when you accidentally shake the camera during taking picture, the image becomes blur. But nowadays, no blurring. Why? Anyone can answer. Any object in the world has got an X, Y, Z coordinate. Through the optical system, this X, Y, Z coordinate location is mapped on the camera pixels. Okay. For sharp vision, the world camera XYZ position must remain projected on the same sensor on the camera during the acquisition time. Now, two things can happen. One is the camera shakes. So, if the camera shakes, if the camera shakes, when the camera shakes, the object which is stationary, then the image moves off of the sensor. Instead of occupying one sensor, it occupies multiple location in the sensor. So you get a blurred vision. Same thing, when your head moves, instead of occupying one cone cell's location, the image spreads multiple location in the retina. So a sharp image becomes a blurred vision. So the first thing, camera shakes. How it will be rectified, I'll explain to you shortly. Next problem is when the object moves. If the image shifts, so when the object moves, the image shifts across multiple pixels on the camera screen. To mitigate the problem in our retina, we use smooth pursuit for slow movement, and we use saccadic system for fast movement. In the camera, to mitigate this problem, when the object moves, the camera uses autofocus tracking system, which predict with a predictive software program. Now, to mitigate blurring of image during camera shake, there is a built-in image stabilizer. So this is, you can see the gyroscope, which is our is a semicircular canal in the camera. So a camera also has got semicircular canal. So it can detect the yaw movement, the pitch movement, and the roll movement. And you have an accelerometer which acts as a utricle and sacule. This is the utricle, and we go horizontal translation. Upward translation is the vertical movement. So you can see on the left hand lower, you can see all these are actually small chips, which are the gyroscopes and accelerometer. So what happens in the camera, modern camera, to solve this, when the camera shakes, we use a image stabilizer. So modern camera solves the problem by using a image stabilizer called IS, or in the Nikon camera is called a vibration reduction. So the gyroscope, when your hand shakes, the gyroscope detects it, and then the lens will move up or down, compensate the movement. If your hand moves down, the lens move up to get a clear picture. Now, that is what VOR works in biological. So Vestibular ocular reflex is a biological image stabilization, analogous to a camera stabilizer that keeps image always steady on the retina during head movement. So it operates independently of the vision and remains effectively even in the dark. With the semicircular canal, when you move, the semicircular canal detects the head movement, and then the effector is your extraocular muscle to keep the image stable during motion. So we can do an experiment. So you can see here, you can see when you're walking, actually your VR is working. So why your VR need to work? To keep the image stable. This is how a VR works. Always when you move, your head to the right, the eye move to the left to capture the image clearly. Now, what happens if your VR is not working? You can actually suppress your VR by looking at your finger and doing one or two turns. And what happens is this, you see, when you turn, you see on the lower, the eye is not moving. There is no nystagmus. So if your VR is not working, the surrounding will be blurred. So, this is, you can see the image, the VR is working. This is your VR is not working. You can see the clarity. The VR is not working. So when the VR does not work, when you have vestibular neuritis or Meniere's disease. So when a patient has got abnormal unilateral VR like this, when a patient has got in acute vestibular neuritis, when you examine the patient will have nystagmus. So what the patient will present during this period is the patient will have vertigo. However, during the recovery phase, although the vertigo improves, the patient always experience blurring of vision. I had a patient after a vestibular neuritis had to see three ophthalmologists, and then basically her main complaint was blurring of vision. So on motion, she had blurring of vision. So this is because of the VR is not working well. So it takes time to compensate. So you cannot be giving anti-vertigo medication for long period, because when you give anti-vertigo medicine for too long for vestibular neuritis, the central compensation will be affected. So the patient will take longer time to recover. So what happens if both the vestibular patient has bilateral vestibulopathy? That means both VR is not working, like due to vestibular toxic medication or due to a cerebellar stroke or cerebellar degeneration, the patient will present with oscillopsia. But patient won't complain oscillopsia. What they will present is actually frequent falls. So anyone with frequent falls, we have to check whether the patient has got oscillopsia or not, and check their vestibular function. Now, with the understanding of how the vestibular system and the eye movement today together work together to maintain balance, let me now apply this principle to a common clinical problem that we see in practice: benign paroxysmal positional vertigo, or BPPV. BPPV is considered benign, meaning not life threatening. However, the term benign might be misleading, because uh, if a patient experiences a fall due to vertigo, it can lead to serious complication. Paroxysmal means it occurs in short bursts and often triggered by changes of head position, and it causes spinning vertigo. Now, BPPV arises when a tiny calcium carbonate, or known as otoconia, dislodge from the utricle. So it cannot dislodge from the saccule because only the utricle is directly connected to the semicircular canal. The saccule is lower down here, so it's not connected. So there's all this basically in BPPV, the crystal has to come from the calcium carbonate has to come from the utricle and migrate into one of the semicircular canal. When the head position, when the head changes position, this dislodged crystal moves into the canal and stimulates the hair cells, so creating a false sensation of motion. So when the patient lies down or stands up, you can see there the crystal moves and causes nystagmus in the eye, which the patient feels at vertigo. So basically, this you can see the video here. When the patient lies down, so the cupula gets deflected. When the cupula gets deflected, you get nystagmus and vertigo. So it's movement of dislodged calcium carbonate crystal in the semicircular canal causes aberrant stimulation in the cupula and subsequently causing nystagmus. So it's a brief episode of vertigo, spinning or triggered by head movement. The classical symptom is normally the vertigo only arises during head movement, such as picking up an object from the floor or top shelf. When they look up and pick up something from the top shelf, rolling over in the bed, or getting up from the bed. Episode of vertigo normally lasts less than 1 minute. However, in cupulolithiasis type can last several minutes. Symptoms can range from mild to severe. In severe cases, especially in the lateral canal, they can have nausea and vomiting. In 1921, BPV was first identified by Varani, who observed that vertigo was triggered by specific head movement. In 1952, Charles Dix and Margaret Hallpike expanded on this concept and formally describing BPP as a distinct syndrome. They also developed a diagnostic maneuver like the Dix-Hallpike test to identify. So BPP is one of the most common cause of vertigo, accounting approximately about 30% of cases. The lifetime prevalence about 2.4%. Incidence about 64 in 100,000 person per year. The average age onset is about 50 years old, with significantly lower incidence in individual under 35. Without treatment, the active phase of BPPV typically can last for 2 weeks on average, but longest I have seen is a patient lasting for 8 years. I have an orthopedic surgeon who came to see me. He said every time he lies down, he have vertigo, and after about few seconds, it goes off. So he did not bother. It took him 8 years to come and seek treatment. So the recurrence rate is roughly about 15% per year, and about 50% of the patient experience recurring episodes. Gender difference, female to male ratio is approximately 2 to 1. This may be influenced by higher prevalence of migraine in women and potentially hormone effect on the calcium metabolism, which could contribute to higher incidence in women. BPP is one of the is more common in older individual due to age-related changes. Accordingly, additionally, the viral infection such as in vestibular neuritis can lead to BPV. So any patient with you diagnose as vestibular neuritis, where they present with first episode of severe acute vertigo, which they can lead into BPPV after 2 to 3 weeks. This phenomenon is sometimes called Heyman-Lindsay syndrome. Other predisposing factors include Meniere's disease or head trauma, which can affect younger population, vestibular migraine, and prolonged periods of bed rest. In some cases, BPP can develop after surgeries involving drilling on the temporal bone surgeries. However, in many instances, the cause remains idiopathic. Now, types of BPPV, we have canalolithiasis and cupulolithiasis. This is canalolithiasis is the most common form, where the tiny calcium carbonate crystals are free floating within the semicircular canal. So they are free floating within the semicircular canal. And the cupulolithiasis is less common variant. The otoconia is attached to the cupula. I will show it to you later. The prevalence of the posterior canal BPPV is about 80%. Lateral canal is about 17%. Anterior canal is about 3%. Bilateral involvement is very rare, almost 90% of these cases being post-trauma. So the take-home message is anyone with after a head trauma, a patient present with positional vertigo, you have to think of BPPV, and this kind of BPPV can be multi-canal involvement. So there are basically 22 variants of BPPV. Now, you can see here, this is the utricle. So these particles from the otoconias from the utricle can move to the posterior canal through the crus commune. So if it is here, this is the canalolithiasis. If it goes down all the way and gets, sorry, I'm not using my mouse. Okay, it gets stuck here. That is called cupulolithiasis. So the crystals on the cupula is called the cupulolithiasis. This is the posterior canal. So the crystals cannot go through this cupula because this cupula is a complete diaphragm. The only way it can go into the lateral canal is through this direction. So it can be in the canalolithiasis, or it can go and attach to the cupula here. And because of gravity is the chances for it to go into the anterior canal is very, very rare. So to diagnose BPPV for GPs, to diagnose BPPV, you have to do two main tests is needed. One is called a Dix-Hallpike test. Maneuver helps to identify the posterior and anterior canal. So we have totally 6 canals. Okay, so the Dix-Hallpike test basically checking on whether the patient has got BPP on the anterior and posterior canal, and Maculo-Pagnini test is for the lateral canal. The Maculo-Pagnini test, also known as supine roll test. So what is important is during this test, clinician must look at the patient's eye, looking at the characteristic of the nystagmus, looking for the voluntary eye movement. This eye movement can be observed by using a direct vision, video nystagmography, Frenzel's glass, or even handphone recording. And by analyzing this eye movement, the clinician can pinpoint the location of the displaced otolith. So, this I'm going to show you how a right Dix-Hallpike test has been done. So the right Dix-Hallpike test actually is checking for the right posterior canal and left anterior canal. A left, that is called this plane, LARP. L means left anterior, RP means right posterior. So a right Dix-Hallpike test is a test to detect whether the patient has got crystals in the left anterior or right posterior. If you do a left disc hall pipe test, you are checking for RALP, right anterior or left posterior. So this is a demonstration of a right disc hall pipe test. So you ask the patient to turn 45 degrees to the right, okay, to make the posterior canal vertical, okay. So then you, after aligning the posterior canal vertical, you quickly bring down the patient to head hanging position about 30 degrees below the horizontal. During this, you have to look at the eye movement. If there is otolith, crystals in the posterior canal. So this normally there should not be any crystals, but if there is crystals, it's going to cause deflection in the cupula, and this will send impulse to your eye muscles. So the eye muscles will contract. So by looking at the eye muscles movement, we know where is the crystals. Okay. So if you do a right, so when you bring up the patient, you also have to look at the eye movement. So sometimes the particle, you can have reversal of eye movement. So what happens is, if you do a right distal pipe test and you find a upbeating nystagmus like this. So during a right distal pipe, if you find an upbeating nystagmus, then you can definitely say the patient has got right posterior canalolithiasis. If the nystagmus is prolonged more than 2-3 minutes, then you can say the patient has got right posterior cupulolithiasis. That means if the crystals in the cupula, the nystagmus is prolonged. If the crystals in the canal, then you have less than a minute of nystagmus. If you have a downbeating, so in your right distal pipe test, if you have a downbeating nystagmus, then you can say that the patient has got left anterior canal BPPV, because the right distal pipe test tests the two planes, the RALP, right anterior and left, left anterior and right posterior. So again, if you do a right distal pipe test and you find a downbeating nystagmus, you say the patient has got left anterior canal BPPV. Next is a maculopectini test or a supine roll test. This is a simple test. So this test had got 5 positions. Position 1, position 2, position 3, position 4, position 5. Position 1 is called sit to supine and look at the patient's eye, whether it got any nystagmus. Then you ask the patient to turn to the right lateral. And in this position, the patient has to be for 60 seconds. Every position has to be 60 seconds, except for the supine position, they need to be in only for 30 seconds. So this is position 2. After the right lateral, you ask the patient to the second supine head neutral position, then position number 3 for 30 seconds. So during this position, you have to check whether the patient has got nystagmus or not. So in the posterior canal, the nystagmus is upbeating, or in the anterior canal, downbeating. In the lateral canal, we call this apogeotropic or geotropic nystagmus, which I will explain to you shortly. So once you completed the test, you can tell the patient whether has got BPPV or not. So here, the patient is lying on the right lateral. So I want you to look at the eye. The eye is beating You can see the eye is beating to the ground. Look carefully. You can see the nystagmus is towards the ground. And this side, also nystagmus is towards the ground. That means the patient is lying on this. So this is called a geotropic nystagmus. So if a patient has got geotropic nystagmus, then which side is the most prominent? That is the side the patient has got the crystal. So in this patient, this has got a left lateral canalolithiasis. That means the crystal is in the canal. If it is in the cupula, then you will have a geotropic nystagmus. That means the nystagmus beats to the sky. I'll show you some more other videos. Okay. So next patient is you look at this eye. So this patient say, I'm turning. So you look at the eye. It's beating towards this patient only had one side, the beating towards the right side, though beating towards the ground. So this patient, right lateral canal low lithiasis. But this patient cannot lie on a right side. Now, look at this. Where is it beating? So you can see it's beating towards the sky. So this is a apogeotropic, geotropic. You can see, so beating towards the sky. So this patient has got a cupulolithiasis, left lateral cupulolithiasis. So since BPPV is fundamentally a mechanical issue, that means the otoconia from the utricle is entered into the semicircular canal. Now the semicircular canal become gravity sensitive. By right, when you lie down, it should not, because in normal person, it should not pick up anything. Now, once the crystals is in the semicircular canal, now every time when you lie down, you turn your head. Now the semicircular canal become gravity sensitive. So the main approach is indeed using a positional maneuver rather than medication. And as I mentioned, the Epley's maneuver is typically used for posterior canal and anterior canal. And the Epley's maneuver is used to treat for the posterior canal. The lateral canal, the treatment is Zuma maneuver. And for the anterior canal is Iacoviano maneuver. That means there is no medication needed for BPPV. So, treatment for posterior canal, we have two maneuvers, Epley's maneuver, Sermon's maneuver. But Epley maneuver indeed is a gravity-assisted maneuver, whereas the Sermon's maneuver is a liberatory maneuver, which involves a rapid movement for patient from one side to other, helping to dislodge the particle from the semicircular canal into the utricle. Both maneuvers are effective for posterior canal BPPV, but the choice depends on the patient's comfort and clinician preference. So, for your posterior canal, and the anterior canal, what test we need to do? Dix-Allpike test. What maneuver to do if positive? We have to use a Epley's maneuver or Sermon's maneuver. For simplicity's sake, I'm going to show you only one maneuver. So this is called a Epley's maneuver. So we are doing a right Epley's maneuver for a right posterior canal BPPV. Turn the patient 45 degrees. So the first part of the Epley's is actually the Dix-Allpike test. So you can see the particles so this is the you turn 45 degrees and bring this is the first part of the Dick-Salt pipe test. So when you bring down the crystals move here. This is the first position. So the second position is this. So when you turn 90 degrees from the, so you have to keep for 1 minute or wait until the nystagmus settles. Then you turn 90 degrees. So this is the second position. So crystals from here migrates here. This is the second position. Next is another 90 degrees. Ask the patient to look down, look at the floor. Okay. So now the third position, the crystals actually goes close to the crus commune. And the fourth position, you must flex the neck so that the crystals actually tuck the chin down to drop into the utricle. So in normally what I do is I do 3 times when I diagnose a patient has got right posterior canal BPPV. At the same sitting, I will do 3 times the Epley maneuver and ask the patient to do Sermon's maneuver at home. This is, and we ask them to do 3 times in the morning and 3 times in the evening for 5 days and come back to see whether the patient has got any more crystals left in the posterior semicircular canal. That's the treatment for posterior canal BPPV. Now, the treatment for lateral canal BPV is a bit complicated. So there are so many maneuvers, Buffoni, barbecue roll, Appiani, or Lampert's maneuver, Zuma's maneuver. For GP, I would like, for the general practitioner, I would like to focus only one maneuver because Zuma maneuver doesn't matter whether it is canalolithiasis or cupulolithiasis. Just use one maneuver. It can treat both. So forget about Buffoni, forget about Lampert's maneuver or Appiani's maneuver. So I'm going to show you. It's very simple. So say this patient has got uh, a right lateral canal, uh, a right lateral canal, canalolithiasis or cupulolithiasis, doesn't matter. So you do a Zuma's maneuver. So this patient is on the right side. So what is the first thing to do is ask the patient to sit and quickly bring down the patient to the right side. So this is the first right position. Wait for 1 minute. So when you do this, the particle from there moves here. Or even in the canal, doesn't matter, it comes here. Sorry. Then the second, ask the patient to look up. So all the particle actually now comes here. Then ask the patient to turn. So it comes to the here. And finally, tuck the chin for another minute. Everything is 1 minute. That's how a Zuma maneuver is done. So two things you have to take home message. One is if a patient has got, most common is posterior canal. If it's a right posterior canal BPPV, you do a Epley's maneuver. If you have a lateral canal, doesn't matter, canalolithiasis or cupulolithiasis, just learn to do one maneuver, which is Zuma's maneuver. Now, let's just want to share you 3 cases. A 46 years old lady complained of positional vertigo past 1 month, triggered when turning in bed, nausea, no tinnitus or hearing loss, past history of migraine. Seen GPs given beta-cert, stametil, stogeron, admitted for vertigo, MRI brain was normal. So this is the VNG eye movement. You can see So this is patient lying on the right lateral, this patient lying on the left lateral. So left lateral beating towards the left side. That means it's a geotropic. Right lateral beating towards the right side. That means patient lying on the right side beating a geotropic. So which side is more prominent? You can see on the VNG graph here, the nystagmus is very prominent here. So normally, if you have a right beating nystagmus, the graph goes like this. On the VNG, right? This is the fast phase, left, right, left, right, left. So if it is a left beating nystagmus on the VNG, this is right, going up is right, coming down is left. Very acute. Right, left, right, left. Okay. So this patient diagnosed as left lateral canalitis BPV. So treatment is left Zuma maneuver. Lateral canal, Zuma maneuver. Now, 38-year-old man involved in a motor vehicle accident, multiple abrasion with no LOC, admitted, MRI brain normal, complaint of positional vertigo lasting for seconds when lying down on the right side. He was discharged with beta cert. Since motor vehicle accident, patient actually uh, develop a fear at night because every time night when he sleeps, he feels he having vertigo. Came to see me, and during the test on this is a disc hall pike test done with VNG assisted. You can see upbeating nystagmus. So a diagnosis of a can see the upbeating nystagmus. A diagnosis of a posterior canalolithiasis BPPV was done. So the treatment is right apply. So to diagnose the anterior and posterior canal, we use disc hall pipe test. To treat, we use Apley's maneuver. To diagnose the lateral canal, we use supine roll test or maculopagnini. To treat, there are many maneuvers. To simplify, just learn one maneuver, which is the Zuma maneuver. This same patient, after 6 months, came back complaining of positional vertigo. So this actually patient had a recurrence. So repeat VNG, again upbeating nystagmus with torsional to the right. So repeat Apley maneuver was done, and till now the patient has got no symptoms. Now case 3, 67-year-old woman with hypertension and diabetes complained of positional vertigo of past 1 week, no tinnitus and nausea. So a Dick's Hallpike test done. What we found that this patient actually, you can see there's a faint downbeating nystagmus on the right Dick's Hallpike test. So if it's a right Dick's Hallpike test, a faint, if you have a downbeating nystagmus, this tells you this patient has got a left anterior canal BPPV. So you can see this is the graph. The right, this is for the right eye. This is for the left eye. So this is the right eye. You can see downward nystagmus. This is for the uh, horizontal movement. This is the vertical movement. So this patient had a left anterior canal BPPV. I just want to show you how Jacobino, the treatment for anterior canal, it doesn't matter right or left. What you need to do is head hanging position for 1 minute. In this position for 1 minute, let the crystals move out. This is called a Jacobino maneuver. So after 1 minute, chin tuck for another minute towards the sternum. and then ask the patient to sit up. However, after 3 repetitions of Yakovinius maneuver, my patient still had prolonged downbeating nystagmus. The take-home message is a patient has got downbeating nystagmus, must be very careful. This can be a central pathology. So a patient, normally in BPPV, they will have symptoms, but if a patient has got nystagmus but no symptoms, especially downbeating nystagmus, you must think of central pathology. This patient was referred for an MRI, and we found that patient had you can see on the right cerebellar area edema, um, indicates of a posterior circulation stroke. On a stroke sequence, which is DWI and ADC, found that the patient had high signals on the DWI and a low signal on the ADC, which is this is a stroke sequence. So sequence, that means shows the patient has got signs of a recent infarct. So the take-home message is proper history is the most important, because there are more than 40 differential diagnoses for vertigo. And 90% of the time, the diagnosis is made through history. Common causes like benign paroxysmal positional vertigo is a mechanical problem. So no medication needed. We must use Dix Hall pipe and maculopagnini test to identify which canal, which side, then treat with repositioning maneuver. If don't treat, risk of fall is very high and persistent postural perceptual dizziness. So, who is a dizzy patient? As you know, so I've experienced a 67-year-old patient with classical. She actually presented with classical positional vertigo. Underwent an exhaustive and fragmented journey through multiple specialties. Uh, she had a CT, MRI, Holter, and repeated referral from patient was passed around from neurology, cardiology, ENT, orthopedics, physiotherapy, and finally to psychiatrics with escalating medication, but without proper diagnosis. Vertigo, especially positional vertigo in elderly, requires thorough history and careful bedside assessment to identify whether it's peripheral or central causes. Early use of positional testing and targeted maneuver to avoid unnecessary polypharmacy. You give them a lot of medication or serial of referral. Instead of bouncing the patient from one specialty to another like a ball, clinicians should acquire good knowledge about vestibular medicine so that they have structural approach. The key message is don't treat the patient like the ball, treat the patient as whole. Thank you.
Thank you, Dr. Puravi, for the very comprehensive review of BPPV. We have about slightly more than 5 minutes remaining. If anybody has any questions, you can either put it in the Q&A box or the chat box, and we'll get Dr. Puravi to answer a couple of questions before we end the session for today. Okay, Dr. Puravi, there's a question here from G. Linky. What do you think about vestibular epilepsy?
Okay, vestibular epilepsy, basically, if you look at vestibular epilepsy, because in epilepsy is basically channelopathies, similar like vestibular migraine, but in a more severe form. Okay, so sometimes vestibular epilepsy can present with dizziness. Okay, so but they don't present like BPPV. Patient might feel dizzy because of ion channel problems. So, some of the treatment for vestibular migraine, if you look at the treatment for vestibular migraine and vestibular epilepsy, is almost the same. Only thing is a lower dose.
Okay, there's another question. How often and how many repetition should one perform the Epley's maneuver for BPPV?
I mentioned earlier, in my setting, what I do, if I diagnose a patient with BPPV, for the first sitting, I will do 3 in one go. Then ask the patient to do at home 3 times in the morning, 3 times in the evening for 5 days, and then come back. I will send the patient the videos how it need to be done.
Does anybody else have any questions? Okay, doesn't look like there's any further questions, Dr. Puravi. So I think with that, I'd like to thank you very much for the giving the webinar for today. And for the participants, the webinar is recorded. So we will send you guys the link to download the recording once it's available.
Okay.
Hey, thank you
Most
so much.
welcome. Most welcome. Hopefully we meet next time. Thank you.